Hi, hello everyone. Today our topic is general anesthetic. Since this is a part of the medicinal chemistry, we have focused on two parts. One is a theory and one is a structure. So first we'll concentrate over the theoretical portion of the general anesthetic. Then we will concentrate over the structural part. So let's start. What do we know as general anesthetic? Anesthesia can be defined as a or can be known as the reversible loss of response to noxious stimuli. What do you call it as a noxious stimuli? Means we cannot able to feel the stimuli which is generating and transmitting to our brain or to the spinal cord. It can be categorized into two parts. One is a general anesthesia and another part is a local anesthesia. General anesthesia is associated with the loss of consciousness fully, when local anesthesia concentrates when consciousness is maintained during anesthesia. Means locally it is withdrawing the pain sensation or any other sensation of a specific part, but in general anesthesia we are concerned with the total part of the body. There is a total loss of consciousness. Balanced anesthesia, it involves few process, few steps. One is unconsciousness, followed by analgesia, followed by muscle relaxation, and most important is the abolition of compensatory reflex response. That is a part we totally becomes unconscious in general anesthesia. So we use some of the pre-anesthetic medication. It is the use of the drugs prior to the anesthesia to make it more safe and pleasant, to relieve anxiety with benzodiazepines, to prevent allergic reaction, antihistamines we know altogether, to prevent nausea and vomiting, antiemetics, to provide analgesia opioid, to prevent acidity, proton pump inhibitor. It's a basic certain medications which should be administered in prior to the general anesthesia administration to have a very smooth effect. So some function of the adjuncts to the anesthesia is given. We don't concentrate on this slide. We go to the next one. Let's start with the begin anesthesia administration. We give the anesthesia, then it is called an induction, followed by surgical anesthesia begins, then it continuously maintain the unconscious state, then we stop administering anesthesia, the surgery is stopped, then comes the most important part, that is a recovery or relevant phase. So it concentrate on the anesthesia administration, the induction, surgical anesthesia begins, maintenance, then we stop the anesthesia administration, then the surgery gets stopped and the recovery. It's a basic part. So the stages of anesthesia of general can be classified into 4:1. Actually, stage 1 analgesia, stage 2 excitement, stage 3 surgical anesthesia, stage 4 imminent death. The breathing, eye movement, pupil diameter, eye relaxes, and muscle tone are the few criteria which you check into account to take to the identification of stages. Like in the stage 1 analgesia, the breathing is normal, the eye movement is also normal, the pupil diameter is also normal, the eye reflex is normal, and muscle tone are also normal. This is a few parts we should concentrate over to know the stage 1. The stage 2, called the excitement, it increased variability. The breathing can be increased. The eye movement will decrease, goes on decrease. The pupil's diameter will be dilated. The eye reflexes will be loosening. The muscle tone will increase, involuntary movement can be seen. The stage 3 is one of the most important part. It basically comprises of four things: one, two, three, and four. And correspondingly, I have given here. You can see that gradually the eye movement is goes to zero, means absent, and the pupil diabetic is fully dilated. The eye reflexes loosening, light reflexes, and so on. This is a part we must concentrate to know the stages of analgesia. So comes the molecular mechanism of general anesthesia. It is a GABA A and the NDMA receptors are both being involved into the general anesthesia mechanism. First, the GABA A is being potentiated by the halothane or propofol or any other agents. The NDMA receptors basically inhibited by ketamines and arosin N2O. So we basically concentrate over here. There are two types of anesthetics. One is a inhalation for maintenance, and another is a intravenous procedure for induction and short procedures. Inhalation anesthetics has few advantage of controlling the depth of anesthesia. Metabolism is very minimal. So up to here, we get an overview of the general anesthesia. Thank you. Hello everyone. In this part, in continuation with the first part, we will know the mode of action of general anesthetics. General anesthetics have been in use for more than a century. But there were few theories which we will concentrate over here. One is a lipid theory, one is a physical theory, one is a biochemical theory, and the other part is a miscellaneous, and most important is a Mayer-Overton theory, which includes a minimum alveolar concentration. So let's start with the lipid theory. Lipid theory basically says there is a direct relationship between the anesthetic activity of an agent and its lipid solubility. That is, the greater the lipid solubility of an anesthetic, it will have more potency. That is, it exhibits a direct relationship between the anesthetic activity of an agent and its lipid solubility. It offers an reasonably acceptable correlation between the anesthetic activity of a compound and its oil water or oil gas partition coefficient, which basically hypothesizes the total theory that more the lipid solubility of the drug, more will be its potency. The following second one is the physical theory. It basically involved in the strength of the van der Waals correlation factor, which is directly related with its potency. Likewise, the size of anesthetic molecules in determining factor for their ability to reach their site of action. That is, it basically says that is a more charged the anesthetic drug molecule is, more van der Waals force it will exhibit. The biochemical theory is involved returns the central nervous system totally, and it diminishes the oxygen intake. It basically interferes with the oxygen supply to the brain, and hence it will have a diminished oxygen intake. There are other theories are also being there, but we will concentrate here over the Mayer-Overton theory. This theory is one of the most acceptable theory. It's basically related with the oil gas partition coefficient. They have studied various membrane-like lipids, octanol and olive oil to establish and determine the lipid soluble properties. The volatile anesthetics, that is the inhalation anesthetics that exist at the time. However, it has been observed critically that the drugs which have reasonably high lipid solubility essentially needed appreciably lower concentration. That is, in the first one we have seen for the lipid theory. That is, a more the lipid solubility, more will be its potency. Similarly, it is also saying the same thing, that more the lipid solubility it will have, so it will required in a very less concentration, that is a lower minimal alveolar concentration, to cause anesthesia. It was the anesthesia molecules afforded an apparent distortion of the former very close to the channel that particularly conducted sodium ion. That is, a membrane has to be subject to squeeze and blot in onto the corresponding channel to bring about two distinctive biological actions. That is, a basically two action has to be accomplished. One is the interference with the sodium conductance, interference with the usual neuronal depolarization. That is, basically it involves the two things. One is a sodium conductance and one is a neuronal depolarization. One more thing we have to know, that is a definition of the MAC. That is a minimum alveolar concentration. The concentration at 1 atmosphere of anesthetic in the alveoli required to produce immobility in 50% of the adult patients being subjected to a surgical procedure. Once more, that the concentration at 1 atmosphere of anesthetic in the alveoli is should be required to produce immobility in 50% of the adult patient which are being going to for surgical procedure. These are the basic theories we should know to judge over the anesthetic drugs and its action. Thank you.